Good evening, everybody. And today I'm going to talk to you about fever with thrombocytopenia and leukopenia. The thrombocytopenia is quite commonly seen, and therefore I will first discuss something about thrombocytopenia and then fever with thrombocytopenia. What happened, Preeti?
Ma'am, click on the screen and then, yes, you have to go back. Yes. Yes, ma'am.
So when we say fever, fever means rise in body temperature. It's actually a defense mechanism. When any foreign organism invades the body, then our body responds to it. You are fighting with the invader, and therefore you require more energy, more calories are burnt, and therefore the temperature rises. It's a defensive mechanism. It's a response to inflammation. Now, this inflammation could be infective or non-infective. We have discussed, I think, non-infective inflammation some time back, but today we will just make a mention about it. Now, leukopenia, whenever there is an infection, the first response is leukocytosis. But occasionally you also see leukopenia. And in which conditions you see leukopenia? If you see leukopenia, it is seen in viral infections, influenza, dengue, rickettsial infections, psittacosis, tuberculosis. As you know, there is lymphocytosis, so there is a leukopenia. Folate deficiency. If you can't explain the leukopenia, please measure the folates, and zinc and copper deficiency. The other causes of leukopenia, along with other cell lines which are depressed, is aplastic anemia. We also see leukopenia if the patient is receiving chemotherapy. We see it in Hodgkin's lymphoma and certain types of cancers. In typhoid, we see relative leukopenia. Typhoid is also a bacterial infection, so we expect leukocytosis, but compared to the fever, the WBC count doesn't rise that high, so there is a relative leukopenia. Thrombocytopenia. We'll come to the discussion little later on, but just to apprise you of the causes of thrombocytopenia, other than the infections, these are alcoholism. So in alcoholics, you see the thrombocytopenia. In cases of burns, where the platelets are sequestered, we will see thrombocytopenia. Aplastic anemia, you will see thrombocytopenia. Lymphoma, HELP syndrome, hypersplenism. Whenever the spleen is big, by the sheer size of the spleen, that it's a big spleen which traps the RBCs, platelets, and destroys them. So we will see thrombocytopenia in hypersplenism. Certain drugs cause thrombocytopenia. The last thing I think you can't see, that is ITP, idiopathic thrombocytopenic purpura. It is a separate entity itself. It is idiopathic. It's an autoimmune disorder. And then we come to the infections which cause thrombocytopenia. Malaria, leptospirosis. These are bacterial, the parasitic and bacterial infections. And then viral infections. It's quite common in them. Dengue, H1N1, chikungunya, HIV, HCV, measles, mumps, and infectious mononucleosis. Which are the drugs which cause low platelets? Heparin, naturally. Quinidine, chloroquine, salicylate, sulfonamides, nowadays we don't use it. Thiazides, rarely used. Allopurinol. Phenytoin is quite a common cause of low platelets. Carbamazepine, trimethoprim, NSAIDs, especially aspirin, because we use it as a low platelet Drug, clopidogrel. Paracetamol does not impair the platelet function, but may cause a thrombocytopenia. So these are some of the drugs which cause a low platelet. Coming to dengue, now the spelling is dengue, but it is pronounced as dengue. It is a Swahili word and it means bone breaking pains. Okay. So the patient complains of bone breaking pains. The pains are in the bones. It's different from our common complaints of our patient. Mittha mittha bukhar aata hai, mitti mitti bukhar aati hai. That is a typical presentation of tuberculosis, remember. Similarly, this bone breaking pains, there is a pain in the bones as if the bones are breaking. And that is the first complaint of these patients. What is the vector? Vector is Aedes aegypti. Only the female mosquito bite as it needs the blood proteins to develop eggs. The mosquito becomes infective 7 days after it bites an infected person. The lifespan of this is 2 weeks. Lifespan of what? Not mosquito, but of the whole cycle. In these 2 weeks, the infected mosquito, there is a reproduction going on. I'll show to you in the next slide. It lays eggs thrice and 100 eggs are laid each time. So see the breeding rate of Aedes aegypti. Mosquito remains infective for its life. The virus is passed down to all eggs. The flight range of this mosquito is 400 meters. But I think 400 meters is good enough in a flat in Mumbai. The space is so limited. The maximum bite is 2 hours after sunrise and 2 hours before sunset. That means this mosquito bites during the day, 2 hours after sunrise and 2 hours after sunset. I mean before sunset. So that is the time when these mosquitoes bite you maximum. There is a febrile phase, sudden onset high fever lasting for 2 to 7 days. Then there is a critical phase and then there is a recovery phase. Now, all people who are infected with dengue virus, they do not develop the disease. 1 in 4 persons develop the dengue. That means it can remain asymptomatic. Okay? That means our body is able to fight against this virus. So these people remain asymptomatic. The virus in the human blood, when the mosquito bites, the virus here in the human blood enters the mosquito. The virus replicates in the midgut, ovary, neural tissues, fat bodies, etc. That means the virus is replicating in almost all organs of the mosquito. Virus enters the body cavity. Then the virus enters here into the salivary gland. And when the virus, when the mosquito bites the human being, the virus is inoculated here into the human body. Now, what is the pathogenesis? This virus, when it enters into the blood, enters into the human body, the local cells carry the virus to the lymph node. And in the lymph node, with our immune system, there is antibody production. But these antibodies, they cover this virus. At the same time, it gets deposited on the capillary walls. And then you get what is called as a cytokine. You know, the different immunological cells are activated, their cytokines are produced, and then we get a cytokine storm, antibody-dependent enhancement. For this, we have to have a susceptible host, and this leads to dengue hemorrhagic fever. The WHO classification of dengue, the dengue fever, either probable or laboratory confirmed, starts with fever, nausea, tourniquet test positive, But this usually is positive in severe cases. In mild cases, we don't get it. Leukopenia and thrombocytopenia. Dengue fever can be mild or it has some warning signs. And what are the warning signs? Abdominal pain, fluid leak, vomiting, the person is listless, there is a bleeding, hepatosplenomegaly, and hematocrit starts rising. Severe dengue, under which we may have manifestations of organ involvement and all the systems in the body are involved. There is a capillary leak, so there can be pleural effusion, pericardial effusion. There can be altered consciousness, the brain functions are affected, the liver functions are affected, the kidneys are affected. So that becomes a severe dengue form. Symptoms: acute onset fever. There is headache, retroorbital pain, which is very classical, myalgia, arthralgia, bone pains, as I said, and there is a rash over the body. How do we diagnose it? The diagnosis is by detecting the dengue antigen. It is NS1 antigen. It's positive in first 3 to 5 days. Okay. Now, just because, because the patient has come to us with fever, we suspect it and we send for NS1 antigen. But there could be asymptomatic people where NS1 antigen is positive, but they have not infected the person. So the infection is confirmed by the body's first response of dengue IgM. So NS1 antigen is detected in 3 to 5 days. The dengue IgM is positive in 5 to 7 days. And then the hallmark of this dengue is platelet count, which is less than 100,000 per cubic millimeter. As I said, the patient, if it is mild, we can manage it even at home. What are the indications for hospitalization? Warning signs are present. So there is hypotension and there are bleeding manifestations. There is evidence of organ damage like rhythm disturbances, listlessness, patient is altered consciousness, and tender hepatomegaly. Laboratory evidence, there is a rising hematocrit. Therefore, in these patients, they come with fever, and if you are suspecting dengue, then first do the CBC, you will find thrombocytopenia and mark the hematocrit. Alternate day, you should do the hematocrit, and if the hematocrit is increasing, that means there is a hemoconcentration. Why hemoconcentration? Because there is a plasma leakage from the capillaries. So rising HCT, evidence of plasma leakage is assessed either clinically or radiologically. And if there is a plasma, the leakage from the capillaries, there a stage can come where the urine output also will be dropped, because all this fluid is getting accumulated in the third space. Okay. And at that time, we should admit the patient. And of course, pregnant women and elderly patients should be hospitalized. In addition to this, diabetes and obesity, these patients also, if they develop dengue, should be hospitalized because they are already immunocompromised and can develop a severe disease. If hypotension, low BP, if there are signs of bleeding, not petechiae, bleeding in the organs, if the hematocrit is rising, if reducing platelet count, the reduction of the platelet count continues, these are the patients we must admit. Pregnant women, diabetic patients, aged persons, chronic kidney disease, and obese people, they are also need hospitalization in case of dengue, because they can turn critical at any stage. What is the management in the mild cases? Complete rest. Now, as I said, there is a capillary leak, and therefore we have to replace this fluid. So adequate fluid intake. Give lots of fluid orally if the person is taking orally. Naturally, in the mild cases, he is conscious, otherwise normal, so he can take plenty of oral fluid. He can take fluids, he can take fruit juices, he can take any liquid, but there has to be adequate fluid intake. Tablet paracetamol for fever and body ache, arthralgia, bone pains. What is important is monitor platelets and hematocrit. So at least every alternate day, we must measure the platelet count and see the hematocrit. Watch for the signs of severity. If there is a sign of capillary leak, if the hematocrit is increasing, then naturally there is a reduced perfusion, so we have to give fluid resuscitation. So do the baseline HCT so that we know what is the hematocrit count, and accordingly, if the hematocrit is rising, we have to give fluid. Saline or ringer lactate. What is the rate? If there is a drop in blood pressure and if there is a capillary leak which is severe, 5 to 10 ml of saline per kg per hour for the first hour. So if the person is 50 kg, 500 ml, that means 1 pint has to be given within 1 hour. So you can imagine how rapidly we have to give the fluid. Okay. So 5 to 10 ml per kg per hour for 1 hour. If there is an improvement, clinical improvement, then we can reduce the rate to 5 to 7 ml per kg per hour, but that we can give over 2 to 4 hours. After that, we can give 3 to 5 ml per kg per hour for next 2 to 4 hours. So we have to completely hydrate him and keep the hematocrit as normal as possible. If the hematocrit increase is more than 20 above the baseline, the patient needs hospitalization. If the hematocrit increases, give more fluid because we have to, there is a capillary leak. So we have to maintain the blood pressure. We have to maintain the perfusion, and therefore we have to give the fluid so that the hematocrit is brought down. If the hematocrit is after your first saline, if the hematocrit is decreasing, then you can slowly reduce the dose of your saline. As I said, first 5 to 10, then 5 to 7 ml per kg, given over 2 to 4 hours. So now we are giving it slowly, and then 3 to 5 ml per kg over next 2 to 4 hours. Okay. In addition to this fluid resuscitation, we also give fresh blood transfusion, but the more important, and now it is available, is a platelet transfusion. When do we give platelet transfusion? The platelets have decreased. Normal is 1,50,000 to 4 lakhs. So when the platelets are less than 1 lakh, we will say thrombocytopenia. But that doesn't mean immediately we have to rush and give platelets. We go on monitoring the platelet, we go on monitoring the hematocrit, and platelets till they drop to 20,000 per cubic millimeter, there is no hurry to give platelet transfusion. Patient may have mild bleeding from gums or maybe little petechiae on the skin. Monitor the platelet. But the moment platelets are 20,000, there should be a platelet-rich platelet transfusion. If it is a single donor transfusion, it is the best. Last epidemic of dengue in Delhi, the Delhi Municipal Corporation or Delhi Health Authorities had issued the mandate that unless the platelet falls to 5,000, there is no need of transfusion. But to be on the safer side, and as per WHO definition and management, we should give platelet transfusion when the platelets are about 20,000 per cubic millimeter. Till then, there is no rush, there is no hurry, but you must monitor the platelet and hematocrit at least on alternate day. Thrombocytopenia less than 1000. Asymptomatic patient without bleeding can be monitored till platelet count is less than 20,000. And when it is less than 20,000, please give the platelet transfusion. What are the breeding sites of this vector? As you can see here, deserted coolers, water storage pots, these tires lying here. The water is collected here, and that is the breeding site for the mosquito. Unused tires, coconut shells, they also contain water, and these are the breeding sites. And therefore, what is important is that we maintain the cleanliness. And I think as a doctor, we must tell our patients about these preventive aspects. Disposable cups, open overhead tanks, water reservoirs, grinding stones. We are left alone like this. Then there are construction sites, okay, and urban slums. So these are the places where there is a breeding which goes, water reservoirs in the high-rise building. So these are the places where the mosquitoes breed and they spread the dengue fever. So as a doctor, it is our responsibility to see the preventive measures also and educate the community, because if there is an epidemic, large number of the patients will be affected. It will affect the health of the community, and who is responsible? Our uncleanliness and negligence for these cases, these things is responsible. So please educate your patient, all the patients for that matter, about these facts of the breeding sites of the mosquitoes. Then coming to malaria. Now I told you severe dengue and dengue hemorrhagic fever, they should be admitted in the hospital. Dengue virus, as you know, there are 4 subtypes. If the person develops dengue with subtype 1, he will develop lifelong immunity for that virus, that subtype. But that doesn't prevent him from getting a second attack of dengue from another dengue virus. And when he gets another dengue virus which attacks him, it is more severe, and therefore he can go into a dengue hemorrhagic shock. So please ask the patient previous history of dengue. Now, for every dengue patient, we are not doing RT-PCR. Therefore, it is necessary that we take the history and we clinically follow this patient. Okay? The mortality is quite less, but the morbidity is high. So therefore, if a patient is complaining of abdominal pain, or if he is complaining of tarry black stools, or there is a tender hepatomegaly, or if a patient is a case of peptic ulcer, which is nowadays rare, but if it is there, then these are the people who are likely to bleed, and therefore they should be hospitalized. Coming to malaria. Malaria is another fever associated with thrombocytopenia. Just excuse me for a minute. Now, this is an age-old disease. All of you are aware about this, malaria and its manifestations. There are 4 types: P. vivax, P. falciparum, ovale, and malaria. But what I would like to bring to your notice is that all of us are getting these mosquito bites, and we are developing subclinical immunity. Okay? And therefore, the classical malaria picture is changing. Previously, it was high fever with rigors, followed by, because of the high fever, then the second stage will be cold stage. So this may be changing. Every patient doesn't come with those severe rigors, but they may come with fever, which is also not very high, but low-grade fever. What is important is the periodicity. And depending on the periodicity, you suspect malaria. He gets abdominal pain at a particular time of the day. He gets headache at a particular time of the day. So this periodicity is very important. Of course, the classical is rigors, high fever, cold stage, abdominal pain is all there. But our clinical picture is modified because of our subclinical immunity. Blood test that we do, it has to be a thick and thin peripheral smear that we test and we classify these parasites. Of course, you know the drugs, chloroquine, age-old, quinine, primaquine, artesunate. At the same time, remember, lots of fluids have to be given and the diet has to be adequate. With artemether, now we have all these combinations. That is the best drug which is available today, and we call it as artemisinin combination therapy. ACT, artemisinin combination therapy, and FDC approved. These are the combinations which are available. I think you take down this chart from the YouTube because I think Preeti will be putting it on the YouTube. So artemether with lumefantrine, 20 milligram of artemether and 120 of lumefantrine. Artesunate and amodiaquine. See the dose, 4 milligram per kg per day, and amodiaquine 10 milligram per kg. Artesunate mefloquine. Artesunate sulfadoxine pyrimethamine. So these are the drugs which are available for treatment of malaria. The problem comes if the patient is pregnant. And therefore, initially, when the patient is pregnant, they were advised MTP. But today, that is not the position. Of course, we have to counsel the patient because it is not the drugs, but it is the disease itself can have adverse outcome of the pregnancy. Miscarriages are common, and therefore, we have to counsel the patient, and whatever it is, we have to treat the patient. So even though there is a pregnancy, we have to counsel the patient that whether with treatment, without treatment, the malaria can have adverse effects on the pregnancy. But with treatment, it is possible to save the pregnancy and of course to save the mother. So in the first trimester, we can use quinine, we can use chloroquine, we can use clindamycin. Artesunate is not cleared for the first trimester. But second and third trimester, we can use ACT combination plus clindamycin for 7 days or ACE monotherapy for 7 days. After pregnancy, the question comes of a lactating mother. Tetracyclines are contraindicated. Naturally, we can't give tetracycline to the lactating mother because it will adversely affect the child. Primaquine is not to be given under any circumstances because we don't know G6PD state of the child. So primaquine should not be given to a lactating woman. Then we come to a third infection with thrombocytopenia. Now, all these infections are more common during monsoon. I think Dr. Asrani has started the series of monsoon-related illnesses. So I am taking it little different title as fever with thrombocytopenia. Leptospirosis or spirochetes, and they can cause a leptospirosis. As you can see here, this is the water in which all these children are enjoying. And there is a lot of waterlogging in Mumbai, in all over Maharashtra for this season. So beware about this. And annually, 70 lakhs to 1 crore cases occur of leptospirosis. It is both in endemic form and epidemic form. 60,000 deaths occur per annum. Human to human transmission is not known. The virus, the spirochetes are excreted in the urine of, the rodents and other animals. So who are at the high risk group? veterinarian, because they are all the time dealing with the animals, slaughterhouse workers, farmers, because they are working in the farms, and that, the water logging, the water can be polluted or infected by these spirochetes from the rodents. Sewer maintenance workers, waste disposal workers, derelict building workers, and adventure tourism. But along with this, let us all remember, in Mumbai, or for that matter, now today in Pune also, or anywhere, there is so much of water logging. And this water which is collected may have the urine from these animals, which will cause a spirochetal infection in the human being. So when we are walking through these water logging, we have to be careful. Clinical profile, it can be mild to severe to a fatal form. What does it affect? The liver, kidney, lungs, brain, and of course capillaries. There is an acute high fever which lasts for 7 to 10 days. The patient, because of the high fever, seeks your advice. Please get this history, whether he was drenched in rainwater, whether he was walking through this drainage or nala water, or the water which was clogged the roads. The patient can have subconjunctival hemorrhage, rash over the body. Because of the liver affectation, there will be jaundice, meningism, and kidney failure. See this water logging. Don't know how to raise this slide. Sorry. This is the subconjunctival hemorrhage, and this is the rash over the body. So one must use the gumboot when they are walking with such a water. If they are walking through this, naturally, see this rodent also here, the dogs will be there, and that urine contaminated, the spirochetes can enter through the skin. Management is antibiotics, supportive treatment. If severe form, naturally hospitalization. And severe form could be so bad that the patient has to be admitted in the intensive care and may require a ventilatory support. Mild, doxycycline 100 milligram BEID or amoxi 500 milligram TDS. Moderate form, ceftriaxone 1 gram intravenous per day or cefotaxime 1 gram 8 hourly. And that is how you can manage. But if there is no improvement, please send the patient to the hospital, because he will require a lot of supportive treatment and higher antibiotics and need be a ventilatory management. Prevention, personal hygiene, which is very, very important. Rodent control, education of at-risk people. So whenever if you are coming through that water logging, the person should immediately wash his whole body very clean. And if you start getting fever, he should immediately report to the doctor. Education of at-risk patients and short-term prophylaxis is given for milkmen and people who are rescuing these people with the rafters. We have to consider them also. And the short-term prophylaxis is with amoxi for 5 days. Chikungunya is African word, that which bends up. Same vector like dengue, clinical profile same, because this is a viral infection. In addition to this, the high fever, body ache, rash, this, that, severe joint pains. It is a self-limiting disease, but the joint pains may persist. And I have seen people who are very badly affected with chikungunya joint pains. Diagnosis by chikungunya IgM, the patient is given rest, paracetamol, drugs for joint pain, but it is a short course you have to give with steroids or NSAIDs, because they can further cause a thrombocytopenia. H1N1 virus, swine flu, another virus which causes thrombocytopenia. Fever, headache, myalgia, same thing, for viral fever, these are the common things. Headache, myalgia, muscle pains are in all these viral fevers. Fatigue, weakness, rhinorrhea, sneezing, and cough. And this should suspect, particularly if there is an epidemic, you should suspect H1N1. What is the treatment? Oseltamivir. If there is only URTI, no pneumonia, then oseltamivir, 75 milligram twice a day for 5 days. If the patient is symptomatic at the end of day 5, then the same dose is continued for 10 days. So you prolong the treatment. If the patient develops pneumonia, but there is no tachypnea, then oseltamivir 150 milligram twice a day for 10 days. So we increase the dose if there is pneumonia. Pneumonia plus tachypnea, patient will require ventilator. Oseltamivir 150 BD plus zanamivir 10 milligram BD. So this requires hospitalization. So I think in family practice, if you make a diagnosis of H1N1 and if the patient has developed pneumonia, on the safer side, it is better to send the patient to a hospital. HIV is a chronic infection, causes chronic fever. There is, in the early stages, polyclonal antibody stimulation. Although it is a disease of immune deficiency, in the beginning, there is a polyclonal antibody stimulation. See, the immune deficiency is cell-mediated deficiency, but initially there is a IgG antibodies which are stimulated, and these IgG antibodies, they cause thrombocytopenia. You may be surprised to know that tuberculosis is also associated with thrombocytopenia. Disseminated TB, so it is a severe form, extensive TB, exudative TB, they all will cause high fever, leukopenia, and thrombocytopenia. So remember this infection also. Now, this hemophagocytic syndrome is not common, which you people will not come across. We see once in a while. And here what we get is ferritin levels are very, very high. Fever, splenomegaly, cytopenia, 2 to 3 cell lines, that means RBC, WBC, and platelet, all are decreased. Hemoglobin less than 9, platelet less than 1 lakh, WBC less than 1000, hypertriglyceridemia, serum ferritin levels are very high, hypofibrinogenemia, and hemophagocytosis in bone marrow, spleen, and lymph nodes that we see. This is not very common, so I will not go into the details of it. The other causes of thrombocytopenia are typhoid, sepsis. In sepsis also there is an immune suppression. At the same time, you will get in sepsis what is called as a disseminated intravascular coagulation, and therefore there will be thrombocytopenia. There is a consumptive coagulopathy. That means the platelets are consumed. Aplastic anemia. That in aplastic anemia, so initially if your thrombocytopenia is persistent, please refer the patient to a hematologist or look for a bone marrow. Viral infections, they all cause thrombocytopenia, and febrile neutropenia. This is a separate entity itself, which can also be associated with thrombocytopenia. And then we have another subset, fever of unknown origin. If the fever is persistent in spite of all your investigations and treatment for more than 3 weeks, we call it as fever of unknown origin. Suspect lymphomas or hidden malignancy. So I think that's all I wanted to share with you about thrombocytopenia. Don't be scared. We can manage the cases. The patient doesn't become critical immediately, but for that matter, we have to be watchful. We have to clinically assess the patient every day. Every alternate day, do the platelet count, hematocrit, and the other tests so that you can diagnose the patient and treat him with proper therapy. I have also told you about the warning signs, and with these warning signs, the patient should be hospitalized. So thank you very much for your patient hearing. If you have any questions, please send them to Preeti. I will answer individually all those questions. Thank you very much. Preeti, over
Thank
to
you.
you.
Yes, ma'am. Thank you, ma'am. Thank you so much for such an insightful session. And as usual, all the participants must have highly benefited from it for sure. Thank you, ma'am. So the questions I'll send you across.
Yes, yes. With a short notice of Dr.
Yes, ma'am.
Asrani, I could do this only.
Yes, ma'am. Thank you so much for this.
If they want, we can go into the details of dengue, because dengue is, has
Yes.
taken an epidemic form. But
Okay.
if all the people are managing dengue, I just wanted to highlight a few points. If they want anything specific, please let them know.
Okay, ma'am. Sure. We'll let you know, ma'am. Thank you so much.
Thank you so much.
Thank you. Thank you, everyone. See you next Thursday. Thank you.